In the world of medicine, every single patient is a puzzle. Every symptom? That's a clue. A doctor isn't just a healer, they're really a detective, trying to piece together a story that the body is trying to tell. And today, we're going to crack that code. And our guide for this little adventure? It's taken directly from a real training manual for surgeons. And I'm not talking about some dry, boring textbook. Think of this as a collection of high-stakes, intense scenarios, all designed to sharpen a medical mind and turn it into a life-saving one. Because let's be honest, that's what it is, right? A mystery. A patient walks into your office with a problem, and the doctor has to figure out the what, the why, and the how. And they have to do it before it's too late. To get inside their heads, we're going to use the exact same tool surgeons use to train. It's called the Extended Matching Question, or EMQ. The easiest way to think of it is as our case file. We get the patient's story, we get a lineup of potential suspects, those are the diagnoses, and our job is to find the one and only one true culprit. Okay, so let's dive right in. Every medical detective follows this crucial 4-step process to crack a case, and we're going to follow it right along with them. First, you assess the story. Second, you identify the critical clues. Third, you analyze the suspects. And finally, you make the diagnosis. Ready? Let's open our first case file. This one's an orthopedic mystery. Okay, so meet our patient. He's a 37-year-old forklift driver. He's pretty young, he's fit, but one day at work, he lifts something heavy and bam, sudden, severe, totally debilitating lower back pain. Okay, now the evidence starts to paint a really specific picture. The pain isn't just sitting in his back, it's a sharp, shooting pain going all the way down his right leg. His back muscles are in a total spasm. And then there's this key test. When the doctor tries to lift his leg straight up, he can't get past 40 degrees without that same awful pain firing up. And here is our lineup of suspects. Could it be something like osteoarthritis? Or maybe a broader spinal condition like stenosis? Or something else entirely? Looking at the evidence, which one is our culprit? The diagnosis is intervertebral disc herniation. Yep, the classic slipped disc. So why this diagnosis and not something that sounds kind of similar, like spinal stenosis? Well, it all comes down to the patient's story. A disc herniation is a classic acute injury. It happens to younger, fit adults, and it's triggered by a specific event, like lifting something heavy. Spinal stenosis, on the other hand, is usually a slow, gradual problem you see in older adults. The patient's age and that sudden onset, those were the definitive clues. All right, let's move on to our next case and see how this all builds, because a surgeon's job doesn't just end in the operating room. Sometimes the real mystery starts right after.
So meet our second patient. He's a 55-year-old truck driver, and he's 10 days out from what was a successful total hip replacement. He should be on the mend, on the road to recovery, but something's just not right.
Now, the clues here seem totally disconnected. I mean, his heart is racing, his oxygen is dipping low, but when the doctor checks his chest, it sounds perfectly clear. The ECG shows an irregular heartbeat. And then there's this one tiny, seemingly unrelated detail. His right calf is all swollen and tender. So what on earth could possibly connect a racing heart and low oxygen with a swollen leg? Is it a chest infection? Maybe a heart attack? Or is it something else that was triggered by the surgery itself? And the diagnosis is a pulmonary embolus, a blood clot in the lungs. This is just a brilliant example of how a clue that seems miles away from the main problem can actually solve the entire case. That swollen calf, it wasn't a distraction, it was the origin story. It pointed to a deep vein thrombosis, a DVT, a blood clot in his leg. That clot then broke off, traveled up to his lungs, and caused the pulmonary embolus. A chest infection would have likely shown up in the chest exam, but a PE can have this weird presentation with a clear chest and low oxygen. The calf was the key. Okay, for our final case, the puzzle isn't really diagnostic. It's deeply human. It's an ethical dilemma where the right medical answer and the right course of action are not the same thing at all. The situation is absolutely critical. We have a 23-year-old woman, she's 28 weeks pregnant, and she has appendicitis. Without an operation, both she and her fetus are at a huge risk. The surgery itself is straightforward and completely necessary, but she says no. So let's just break down the stakes here. The medical facts are crystal clear. Surgery is the safest option, period. The patient has been told this, she understands it completely, and her answer is still no. Now, to complicate things even more, her husband is right there, pleading with the doctors to please just do the operation. So, what does the surgeon do? These are the potential paths forward. Can the surgeon just operate based on the husband's consent? Should they take this to the courts? Or is the patient's refusal the absolute final word?
The answer is unequivocal. The surgery cannot proceed.
And the reason for this comes down to one of the most fundamental principles in all of medicine: patient autonomy. A competent adult has the absolute right to make decisions about their own body. They can refuse any treatment for any reason, even if that decision seems medically wrong to everyone else. Not her husband, not the doctors, only she can give that consent.
So, after walking through these incredibly different cases, what if we learned about what it takes to crack the clinical code?
Well, it's about having a whole toolkit of thinking skills. We saw pattern recognition with the forklift driver, whereas age and that sudden injury just screamed slip disc. We saw how important it is to eliminate red herrings with a truck driver, realizing his swollen calf wasn't a distraction, it was the source of the whole problem. And maybe most importantly, we saw the principle of patient autonomy, where the pregnant woman's right to choose was the final, unshakable factor. It's about remembering you're treating a person, not just a diagnosis. Which really leaves us with one final question. When you look at the logic, the ethics, the pattern matching, and the raw human element we've seen today, is being a truly great doctor more about mastering the science of medicine, or is it about mastering the art of humanity?